remove the unsupported enamel, because in permanent the enamel rods are pointing apically. Okay, so it's the other way around. It's up. Yes, the downward. So the most superficial, the most outer surface will have unsupported enamel, the enamel which are just part of enamel rods. So that is why we need to remove. So an amalgam preparation, we need to know this difference. But now we're not doing amalgam anymore. So now this has become irrelevant, and I will not ask you this in any form of MCQ questions. But yeah, these are the major differences. Okay, we'll go to the next slide. Yeah, so this is, now I'm going to ask you in the picture D and M, which is the permanent molar and which is a primary molar, D or M?
D is the permanent, M is the primary.
Okay, so the morphology is very, very clear. So what is marked in the black line is the cervical enamel C junction. Okay, so in permanent, you see the C junction is nice and smooth, but in the M for the primary, it is got an S shaped. Okay, now this S shape is where near the M there is a dip in the cervical margin, because there is a cervical bulge, because of which the cervical line is bulging down. Yes, that part. Okay, you see the bullet. So above that line is something called as cervical bulge. Because of that bulging, the line has dipped. So we use this bulge when we are doing stainless steel crown to have some additional retention. So when you are identifying tooth as permanent or primary, we look at the cervical bulge to decide if it is a permanent or a primary. Now, important thing that I want all of you to note is that teeth primary second molars, maxillary or mandibular primary second molars, will have same morphology as their permanent counterpart. So that means if I am saying tooth 8-5 is my primary second molar, it will look same as my 4-6. Only the size difference will be there in the occlusal surface. So this is very important to identify. So 8-5 will look like 4-6 but smaller in size. So 7-5 will look like which tooth but smaller in size? 7-5 will look like which? 3-6. Okay, so 1-6 will look like? 1-6 will look like which primary tooth?
5-5.
Very good, 5-5. And then 6-5 will look like which tooth? 6-5 will look like?
2-6.
2-6. Okay, so we make mistakes in crown identification by interchanging the numbers. So just imagine, just remember that. Okay, so now the root length is also very big. If you see in the D and M, the root length is long as compared to the primary. Then you see in the permanent, the root are more or less cylindrical and long, while you see the roots in the M is more flared out. Okay, like the yellow arrow shows. Can now anybody tell me why is there a need for flaring of the roots in the primary molar? Why has God flared the roots for primary molars?
Because the tooth wants to erupt.
Yes, the growing
permanent.
The permanent tooth development is in between the roots. So that is why God has flared it. So the tooth development of the permanent will happen there. Okay. So this makes our endodontics in pediatric very difficult, because flaring of the root is there. The root are very narrow. So we'll look at it later. Now we look at the incisors, central incisors. Okay, this is where we discuss the mamelons. Mamelons are present in the permanent, absent in the primary. Okay, and another feature that we need to look at is the occlusio or incisal gingival length from the incisal edge to the CEJ. Okay, can anybody tell me the difference between distance between incisal edge and CEJ between the primary and the permanent? Which is longer? Okay, let me rephrase it. The crown of the primary tooth resembles a geometric shape, and the crown of the permanent resembles another geometric shape. Which shape are we talking about for primary and for permanent? Can put in the chat. I think I can open the chat. I can. Geometric shape of your primary incisors. Okay, geometric would be more like, trapezoidal, square, rectangle, triangle, those shapes. So primary molar is what kind of geometric shape?
G square, doctor.
Yes. Okay, and the permanent?
More to a rectangle.
Very good, rectangle. So this is also a very important identification point between primary and permanent. Okay. Of course, the root length is longer, root or resembles more or less the same. Okay. Right. So this is very important. Yes, that's a square, and the other one would be a more like a rectangle. Yes. Okay. So it's a very important differentiating point. Okay. So when you are doing restorative work, you must remember that you have to build up a primary central incisor in a square shape and a permanent incisor in a rectangle shape. And you also see the grooves on the labial surface of the permanent. Are they grooves? Yes. Yes. So what mistake we make when we are doing a aesthetic restoration on the permanent incisor is we do not make these grooves, and our restoration looks very artificial because it's just plain. Okay, so when you're doing a distance between the pulpal floor and the furcation. So in the permanent, it is a lot. Okay, in primary, it's very less. So that means if you're doing root canal for primary teeth, your chances of perforating the root is very, very high. Okay, unlike in the permanent, where the root trunk is big, chances are very less that you will perforate the pulpal floor into the furcation area. So this is also we need to remember in terms of the morphology, because it will help us in planning our endodontic treatment. So in primary teeth, when we have caries which is reaching up to the pulpal floor, then we do not do any endodontics, because we know that we cannot do excavation for the pulpal floor, it will perforate. So we have to go for extraction. So these are some clinical knowledge that is applied for your morphology of deciduous teeth. Okay. Right. And even for extraction, yeah, go ahead. Next picture. Next picture. Right. So this radiograph typically shows your primary second molar and the permanent first molar as a radiograph. Okay. You can nicely see the flaring of the root, the length of the root, the length of the crown. Can anybody tell me what is that radio opacity on the primary molar?
Restoration.
Okay, restoration. But where is the roots are flared? But where is the developing premolar?
So retain deciduous, doctor.
So this is supposed to have the succedaneous premolar, right? I don't see the premolar in the radiograph. Where is it? It is congenitally absent. Okay, so that is why we took the radiograph to find out if the premolar is there. Should we extract the second molar or not? So when premolar is congenitally missing, then we will retain the primary second molar for as long as possible. Okay, so yes. So the thing should be there. So it's congenitally absent. So that is why we know that flaring of the root is to accommodate the premolar. So now in the picture next to the radiograph is how the maxillary will look like. Okay. So maxillary will look like is most prominent difference is in the root trunk. Okay. I can see the root trunk is there. The flaring of the root is much more. Okay. And there, yes. Now what happens is when you're extracting the maxillary, the crown will be so grossly destructed that it will involve the furcation area. And when you extract the tooth, you will definitely break the crown. And then you have to individually take out the root. So it's a task. Okay. Now the bulge can you see on the buccal surface of the maxillary molar that we were just talking about. Primary molar has got a bulge, which is much more bulgier than the permanent one. Yes. Okay. So this bulge is there on the labial surface and also on the proximal surface. Okay, so we just remember this part. So it's called as cervical bulge, not so much on the permanent. Okay, awesome. Okay, so we go to the next one. So the next one shows the pulpal differences. Okay, here when remember in the radiograph, if you zoom in on the radiograph, we were talking about how the pulp horns are more projecting into the dentine as compared to the permanent tooth. Yeah. And then we see the thickness of the enamel on the permanent and the primary, and we see the thickness of the dentine on the permanent and the primary. So everything is less in the primary. So that means caries involvement in the primary happens much quicker in the enamel, and it goes into the dentine, spreads much faster because the thickness of the dentine is less and reaches the pulp. So by the time the patient comes to us, he already has got an dental abscess because they have not reported earlier. Okay, so this radiograph shows a very nice difference in the crown, the thickness of the enamel dentine, the pulp morphology, okay, the root morphology, and of course the presence of the succedaneous tooth under the primary molar. Okay, it's partially seen, but it is there. Okay, so yes, this picture explains. So now when you look at the picture and you read the description, you will understand everything is there in the picture. Okay, we go to the next one. Yeah. So this also shows how are the canals in a primary molar. Okay, so this is a picture of a primary molar, and you see the root canals in the primary molars are very flat. They're not round and cylindrical. So if you're doing your rotary endodontics, it's very difficult because the canal is flat. Okay, you see the mesial canal is so flat. So cleaning and shaping is impossible like how you do in the permanent teeth. So therefore, now if you look at the picture below, you have these flat canals, which is again having two different apical openings. And you can also see the pulp projections, how they are high. Okay, so this makes pediatric endodontics even more difficult and unpredictable. And that is why in US, they want to go for extraction of a primary molar with an abscess. But in India and UK, there is tendency to do root canal treatment for abscessed molar and trying to save it. Okay, so this is because of the difficult anatomy, pulpal anatomy. So like in permanent teeth, you go for cleaning and shaping of the canals. So you clean the canal and shape the canal to receive the gutta percha filling. But in primary teeth, we do not have cleaning and shaping because we just cannot shape the canal into a nice conical shape. So our objective for root canal in primary teeth is disinfecting, pulp removal and disinfecting the canal. That's all we can do. And then we cannot put gutta percha. We have to put something called as zinc oxide digenol or a resorbable paste into the canal system, and then make sure it remains there till the deciduous tooth exfoliates. Okay. Not GP. Why GP I cannot put in primary teeth? Number one reason is I cannot clean and shape these canals to receive a GP. Number two is gutta percha is not resorbable. So when the primary permanent premolar is erupting, the gutta percha will not get resorbed and it will cause hindrance to the eruption path and deflecting the premolar somewhere. So we do not use gutta percha for primary teeth. So this we will learn more in the lecture for pediatric endodontics. But for now, we just understand how the pulp morphology makes life difficult for us if you want to do a root canal. Okay, so now in the next slide, we have more differences in terms of histological. Okay, so there are two radiographs. The radiograph on the left, if we can zoom, okay, and we find that there is all primary teeth. Primary canine is there on the right, then primary first molar is there, the primary second molar is there. The primary first molar has got radiolucent lesions in the enamel, which is covering enamel dentine and has reached pulp. And in the pulp, there are two roots, one on the right side, which is the mesial, one on the left side, which is the distal. Can anybody tell me why mesial root canals are nice and smooth, but the distal ones, we got a bulge, radiolucent bulge in the distal root? What is it called as? These kind of radiographic image is called as internal resorption. Okay, so this tooth is typically showing internal resorption. So the tooth is resorbing from the inside. Okay, now very important thing that I ask in the MCQ question is, the pulp of primary teeth is programmed by God to become clast-like cells when stimulated. Which kind of cells? Clast. Okay, like odontoclast, osteoclast, cementoclast. These clasts are basically the cells which will remove these structures. So odontoclast means they will remove dentine. Osteoclast means they will remove bone. So God has created primary pulp to become clast-like cells, then only the resorption can happen. Otherwise, these roots of these teeth will never get resorbed. The permanent will never have a chance to come out, okay, for resorption. Unlike in the permanent, God has programmed the pulp to be blast-like cells. Okay, blast-like cells. So the pulp of the permanent teeth will become odontoblasts when stimulated. They will become osteoblast. They will become cementoblast. Okay, so that is why now if you see in the radiograph on the right is a radiograph of a permanent tooth, and you see the pulp chamber. What do you see in the pulp chamber? These are permanent teeth.
It looks like calcification.
Very good. It looks like calcification because the pulp is programmed to be blast-like cells. So this could be cementum-like structures or the dentine-like structures, or this could be pulp stones, calcification. So that is a major difference. Okay, so we will never find a pulp stone in a primary tooth, but we can find a pulp stone in the permanent tooth. Okay, we will find more internal resorption in primary tooth as compared to the permanent tooth. Okay, so if you see an internal resorption in the permanent tooth, it's a classical feature for a asymptomatic irreversible pulpitis. Okay, but in the permanent also we have. Now, since we are on this picture, you see the furcation area, the area between the two roots. It's showing radiolucency. Yes, that area is showing radiolucency. As compared to the second molar, if you see in the second molar, there is no radiolucency. So we call the second molar is more like trabecular pattern, which is considered as normal. These are the trabecular pattern. Okay, these are considered normal. But for the first primary molar, we have a radiolucency. That means it's a dental abscess already. We call it as furcal abscess, or we call it as a dentoalveolar abscess. So if you find a tooth, primary tooth with the deep caries with furcal radiolucency, that means the pulp is already necrosed or partially necrosed or cannot recover on its own, must have to be removed. So this is a good example of how the furcal abscess happens. Now the question here is, primary tooth will have furcal abscess, but the permanent tooth will always have a periapical abscess. In permanent dentition, permanent molar, you will never see furcal abscess. You will only see periapical abscess. The reason is, on the pulpal floor, we already know the root trunks are very narrow. The distance between the pulp floor and the furcation is very narrow as compared to the permanent. Okay, So what happens is infection from the pulp can easily go into the furcation area if there are wide accessory canals in primary molars. So that is why in primary molars, because of these wide accessory canals on the floor of the pulp chamber and the thickness of dentine is very less, we have more furcal abscesses in primary as compared to the permanent. In permanent, the distance between the pulpal floor and the furcation area is very thick. So even the widest of your accessory canals cannot travel so fast. By that time, the infection will travel through the root into the periapical area. Okay, so very, very important. So if you see a radiolucency in primary molar, it's already an abscess. Okay, and then we need to do something about the abscess. Okay, good. So here is just the quiz that I want to ask about what is A, B, C, D, and E and F. So you can find it in the next slide. Okay. So this, what kind of X-ray is this? It's a bite wing X-ray. Okay. And the AB corresponds to the AB in the previous picture, not on the X-ray. So in the previous picture, you have AB is the thickness of the enamel and the thickness of the dentine. So here in periapical, you can very nicely see the permanent molars are there on the right, and there is primary second molar, then the primary first molar. So maxillary and mandibular, you can very nicely see in this radiograph. Okay, that is the thickness of your enamel and dentine. From occlusal surface to the pulpal floor, the permanent has a very long distance as compared to the primary. Okay. Now, one of these primary molars have got a the radiolucency in the proximal surface. Can Amanda identify the radiolucency? Which primary molar has got a radiolucency on its proximal surface? Can circle it for us.
Sorry, doctor, can you repeat? Which primary molar has a radiolucency?
On its proximal surface.
Maybe this one.
Yes.
No.
So
Yes.
this one is the cervical area. Okay. So this can be attributed to cervical burn that we call in radiology. But if you look above in the crown, you will find that there is a radiolucency in the dentine. Yes, there. Okay. And similarly on the upper first molar also, there is a radiolucency in the crown. So you will see on the distal side also, yes. So normally the enamel should appear as a white thick line, but in these two teeth, the line is disrupted. So when you take a bite wing and you follow the enamel line and you see there's a break in the line and there's a radiolucency, that means caries has already started. Okay. Now another thing that I want all of you to note here is the contact point between the primary molar is more or less flat. But contact between the permanent molar and the primary second molar is more like a point contact. Okay, can you all look at the contact point? Yeah, interproximally, Amanda. Not occlusally, interproximally, the contacts between primary first molar and the second molar is more or less flat. As compared to the contact.
Yeah, doctor. Where? Here.
Yes. So that is a contact point. As compared, it's more flat as compared to the.
This one.
Yes, this more point-like. So because this flat contact point is there in primary, the food lodgement, if there is under the contact point, it's not going to come out very easily. But in the permanent dentition, it comes out easily because it's only point contact. Your embrasures are very big. So any food that goes into the contact area will come out. So that is why in primary molars, you will see more interproximal caries if the patient is not flossing her teeth or his teeth. Okay. So flat contact point is also there. So this is a good radiograph which depicts everything. point contact. Okay, so I think that is all we have. I need to show you, of course, the pulp horns. Also, you can appreciate how the mesial pulp horn in the mandibular is high. Yes, that one is quite high. Okay, so that is why if you're doing cavity preparation and you have got an interproximal caries, chances of pulpal involvement is very high if the caries is interproximal and already 0.5. So we need to take care of our caries excavation. We should not do heterogenic caries exposure and then land in a problem. All right, good. So that is all I need to show you in this one. We'll go to the next slide. Okay, so now there are more features. C and D cervical ridges are more pronounced, especially in the buccal aspect of the primary molar. We have already seen. Now, Amanda, can you zoom into the radiograph? Okay. Now you have primary first molar and primary second molar and primary permanent first molar in the mandibular. So if you follow the contact point of the primary first molar, okay, you find that there is a constriction when it reaches near the pulp. So your crown and pulp, where they join, there is a constriction there. What we initially said was a burn on the root surface. On the distal part of the tooth, if you draw a line from the crown, from the occlusal surface of the crown, on the distal surface, we are in the canal now. Amanda, you want to come on the distal surface of the
like on the side.
Yes, sure. Now you see the line. There is a constriction where the crown and the root meet. Okay, so can you draw the same line on the distal surface of the tooth? Distal surface. What you have drawn is on the mesial surface.
Oh.
Yes, you see that? The constriction? Yes. Now draw the same constriction on the permanent molar. You see? This is more smooth, but there the constriction is quite evident. Yes, that part. Okay, so we must remember. So when we are putting a matrix band for developing interproximal caries, okay, it's very difficult with a flat contact point. The matrix band will not go in with some difficulty, and then adaptation of the matrix band to the tooth surface will also be difficult. And this is a common reason why restorative failures are there. So you need to get a nice gingival seat and a good place for the matrix band to come. Okay, so just remember this point. Okay, we'll go to the next one. Okay, so now we will skip because now this is physical. It's just repetition of what I've already told you. So you can just follow the text, and the photograph is given. You can just compare to the text. Okay, again we are looking at the roots and the flaring and things like that. We go to the next one. Okay, so here we are talking about the flat and broad contact points. So in this particular bite wing, you will see on the mandibular teeth how flat is the contact point. Yeah, and because of which there is radiolucency in. Yes, it's very flat, and the caries has already happened on both the molars. There is a radiolucency, yes, there, and on the other molar also. So when you're looking at radiograph, you need to take a nice good radiograph, then only it will become diagnostic for us. Okay, so this just tells us about the flat contact. In the maxillary also you have flat contact. It's not that in maxillary you do not have. In maxillary also there's a flat contact. So all these teeth are very prone to interproximal caries, and the patient will only come to you when there is pain. That means the caries are already spread so vastly that is now the pulp is inflamed. So very difficult for us. That is why we keep applying sealants, topical fluoride everywhere. Okay, we go to the next one. Okay, so this is in summary of what we have already learned. Okay, this is just the highlight of the summary. Okay, and we'll go to the next one, and you can practice tooth identification from this OPG. Okay, so we already know how many primary teeth are there. We already know where the permanent teeth are developing. So as a practice, you can look at this OPG and you can try to identify the teeth which is already in the mouth, teeth which is there in the bone, and can give me a dental age of this patient. Okay, so that was the exercise for you. Okay, go to the next one, Amanda. Yeah, and these are the teeth identification. Okay, what I was telling about how the molars, primary second molar, resemble the permanent first molar. Okay, so this is just to show that. All right, good. And when you're doing tooth identification, always start from the midline, because incisors are very easy to identify. So if you identify an incisor, then you already know next to the incisor will be a lateral incisor. Next to the lateral incisor will be a canine. Next to the canine, maybe a primary molar or a premolar. Okay. So this slide just goes on to tell you the resemblance of molars, primary second molar and the permanent first molar. Okay. Yeah, good. That's done. Thank you so much for everyone for joining online. Okay, it's very boring to deliver online, but I think all of you stuck together. So thank you for that. Any questions, be free to come and ask me in the clinics. Okay. And have a nice weekend. Those who are traveling already, have a safe journey home and enjoy the Deepavali vacation. And those who are not joining, I'll see you tomorrow. Okay, take care, everyone. Thank you.
Thank you, doctor.
Thank you, Doctor.
Thank you, doctor.
Thank you, doctor.
Thank you for attending. Thank you. Thank you. I'm gonna log off now. Okay, see you tomorrow. Thank you, everyone. I will log off in the end. Okay, I'll just wait for all the thumbs up first to come, so I feel motivated to take the next lecture also. Then I will sign out.
Doctor,
Yeah.
Doctor, I think year 3 need to stay back for the scholarship holders.
Oh yeah. Okay, Dennis is there. Dennis, Jojo, have you left? Totally forgot. Okay, so for the scholarship students, we are required to put in 120 hours of scholarly hours, what we now refer as, okay, for the institution. All right, now 120 hours in 5 years. So year 1 and 2 already passed, and I'm sure we have not done anything there. So, but carrying on from year 3, 4, and 5, we will try to fulfill as many hours as we can. Okay. So by the time we finish your year 5, we must have something close to 120 hours. So 120 hours in 5 years, I'm going to minus the first 2 years and just look at the next 3 years. Whatever remaining hours for the next 3 years, minimum, we must fulfill it. Okay. Now we have Denise and Jojo have been put in charge for tracking each person's scholarly hours. So if Denise can show her Excel sheet here, all of us will know how the tracking is happening.